This week on the BackTable Podcast.
Plus, a negative angio is just the dead worst.
It just sucks, It's just Friday, negative angio. You're scared you're going to get called in on Sunday for a rebleed.
Called in. Plus, it's like embolizing a lower GI bleed. So fun.
It is so much fun. I agree with you. That is like
a positive one. It's like, and then you find it in teeny little branch there. It's like, this is fancy. This is super fancy. This is, this is what I'm paid for.
I agree. And it's so funny. We take it for so granted, right? Like, it's just like, but like, there's so much stuff and skill that we've learned to do it. And then it's such a remarkable result.
It is.
I think that's why it's so satisfying too.
Yeah.
Right?
It's like
it's microcatheter skills, it's diagnostic skills, it's decision-making skills, and it's all within like 20 minutes.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable Podcast.
Welcome to the BackTable Podcast. This is Mike Barraza is your host. I'm joined by my friend and partner, Sabeen Dhand, my other host. What's up, man?
What's up? Welcome. It's kind of fun to be on this side right now.
I know. I like doing it this way. No pressure at all. And you already know the rules. If you say something bad, we just cut it out.
I'd like to conclude it, actually. I'd like to include it to all the listeners.
But we've done this before. We're going to talk about provocative angio for lower GI bleeds, which sounds kind of scandalous. But we talked about this before, but it's probably like 2 years ago.
I know. And I think it was mixed into a GI bleed episode.
I think it was.
So I think something that'll be nice about this episode is just like, this is about provocative angio, and people can refer to it because I get a lot of texts and I get people asking me like, oh, how do you do your protocol and stuff? And I think it's just a very nebulous procedure. It's a little scary, it's a little cowboyish. So I think we thought that having a short episode dedicated to it for reference for people would be good.
And one of the things you told me is that you wanted to kind of bust the myths surrounding provocative angio. So what are the myths?
The questions that I've gotten in the last year or so is just, what's the max TPA? And like what is, I'll only do like some small, minute, like you do too much. So I just wanted to bust the myths. Like, why are people timid to give TPA? Yeah, the patient is bleeding, but there's been several studies, including one that we published in my old group, that there's no major adverse events, even with TPA up to 50 milligrams, right? So, yeah. And I learned this protocol. I have to give, full, kudos to Al Nemchek from Northwestern. He was the one who did provocative angio at NU, and he was one who just give a lot of TPA. It's fine. Like you'll find the bleed, you'll stop it. And I think that kind of inspired, me to adjust the protocol to what we use. And we can go over that protocol. But yeah, I just think there's a lot of myths. People are scared about it. Do you need surgical backup? Do you need to make this whole hoopla in the hospital that you're going to do this, quote, experimental procedure? Honestly, it's become like normal procedure, like requested at my hospital.
No kidding. Well, let's take a step back and let's look at it from the beginning. We're doing provocative angio, and this is exclusively for lower GI bleeds, right? You're not doing it anywhere else in the body.
Yeah. Lower GI bleeds is what I'm doing it for. One time we did it and it elicited an upper GI bleed.
No way. Yeah. But I mean, to clarify, for upper, you already know where you're going most of the time.
Sure.
Before you're doing it. And you can be a little more aggressive with upper GI bleeds. You don't see anything, you can bag the GDA. You can take out the left gastric. You don't have to worry about it. With lower, you've got to be more specific, right?
Totally. And yeah, you want to be as selective as you can in the lower GI bleeds so that you take care of it that time and it doesn't recur.
So let's talk about how this starts and how you get from, we've got a lower GI bleed in the hospital. How do you get from there to the provocative angio? Because you're not doing that right off the bat, right?
Not all the time. So I'll tell you my little modified stuff about doing it, in the first angio. But yes, let's go what we usually do and then what happens.
Including the diagnosis.
Yeah. So generally, this type of procedure is for patients who have had recurrent GI bleeds, recurrent admissions, usually requiring some sort of transfusion, and workups have been negative. At least, therapeutic workups have been negative, being colonoscopy, negative angiogram, and they still keep on coming. Even to if it's going to be the second time that they come and this is happening, we plan to just set up the patient for a provocative angiogram.
So tell me this, you say negative angiogram. Are you talking about a CTA or you've already done a catheter angiogram?
Both. So you do CTA, it's negative. And then for some reason, and this is where different hospitals are varying protocol. Some won't do an angiogram with a negative CTA. In my group, we would still do an angiogram if they were bleeding significantly.
Okay.
And let's just say that first angiogram was negative. And we thought, okay, there's nothing to do. Patient goes back to the room and they don't bleed. They get discharged and come back 2 months later with a lower GI bleed.
Before we get to that, let me ask you another question. When you're looking at it, so we're talking now about like a unidentified lower GI bleed. We don't know where it's coming from, right? It can be anywhere in the lower GI tract. Let's talk first about when we do know where it is, either by colonoscopy or by CTA or tag red blood cell study. Let's say, we know that the bleed is in the descending colon.
Sure.
And you've done your angiogram and nothing lights up. Are you gonna do the provocative angiogram the same way that you would if you didn't know where it was?
No. If I knew where it was, then I tend to be, selective into the most parent vessel. So I would tend to set up everything. I prefer GA. I prefer to have everything controlled, keep a couple units that are crossed. And, if I knew it was coming from the, descending colon, then I'd focus on the IMA. But if I'm thinking of right colon, I'd focus on the SMA and really kind of go aggressive in that territory. If I did not know, then I would actually get bilateral access and do both SMA and IMA.
Okay. So you get access. Okay. So we're gonna go through that. I want to hear all the steps. So back to what you were saying, negative angio, negative colonoscopy, then they call you.
Yeah. And so say they had a history of negative angio, CTA, and then a conventional angio is negative, a patient comes back, whether it's the same admission or another admission a couple weeks later, a month later, a year later with nothing definitive done the first time, and now they're bleeding again. At that time, I'm already thinking, I'm going to provoke this bleed.
That's nice though, because it's not, a lot of the time when we're trying to do an angio for a GI bleed, it's like, we got to time it for when they're bleeding. Like they're not bleeding, like, all right, let's not do it right now. And then, you hear it's like, they're bleeding. It's like, get them down right now.
Yeah. No, it's like, I'll make them bleed, at our time.
Yeah.
When we want it, So I would say we're pretty aggressive at that point. The second time they're bleeding and at the first time there was no definitive action done, we would just plan for this provocative PMA protocol, where the patient is, again, under GA. Hopefully we're localized right or left, and then we can focus on where we're going to inject the thrombolytics.
Okay. How are they localizing right or left usually?
A GI bleeding scan, if you have that showed something at some point. CTA maybe was positive, back in the day. And again, it's been a negative workup, or colonoscopy. Sometimes it might just be, there's a lot of ticks in the sigmoid colon. Where else would they be bleeding from? And I'll use that as a localization.
But sometimes you don't have any localization. It's just they're bleeding.
They're bleeding. We don't know. There's a lot of ticks. I'm sure we've all seen, they say the colonoscopy, it's all old blood. We don't know where it's coming from.
So you do this at GA?
Yes. I personally like GA. One is that, you have one variable controlled. The patient is, not moving. You are doing something that, if eyes are on this, you have to kind of sometimes explain to you, be able to explain that you're doing something safely, right? And a lot of people, when they hear I'm going to throw 50 milligrams of TPA at a GI bleed patient, they'll think you're an idiot, right? Hi, that's me, right? I like GA for the fact that it's quote safe. And the other fact is I love breath holds. Like, I mean, if I'm doing GA, it's going to be a breath hold. You're going to carry out that SMA run for 10, 15 seconds.
Okay.
The bowel, there's going to be no breath. The only movement you're going to see is peristalsis.
And that makes a huge difference. I mean, how many times
Yeah.
do you get faked out when you're doing angiogram? Like,
Yeah.
oh, there it is. Like that's it. Then it's nothing.
And you know what's funny is you just think you're going to give TPA and it's going to pour out bleeding. There's been so many times where you get TPA and then finally, after 25 milligrams, etc., like you just see this little blush starting somewhere and you're like, oh, there's the bleed. And it's never like just pouring. And it literally just took that much just to get it like a little touch of bleeding. Then you finally find it.
Damn.
And then when you get closer to it, it's more obvious, but it's not like that, positive CTA bleed where it's pouring out and you can actually make out the hostra or whatnot. Like it's rarely like that, even at high doses of TPA.
So walk me through it.
Yeah. So we'll go through a localized one and then a non-localized, right? So what I like to do is if we're going to focus on the SMA, so we're thinking the bleed is coming from small bowel or ascending colon, I'll get access, I'll plan to close my access. I don't plan to do, hold pressure or anything, right? These patients are very thin.
Prone to bleeding for sure.
Yeah. And so SMA, something that I like to do is I like to put a 6 French sheath into there. So I'll put, whether it's an Ansel and I'll make a little curve and I like to seat it in there because
So you like to get it into the SMA.
I do, because I like the runs. If you notice, I mean, just imagine a run from a microcatheter in the proximal SMA, a 5 French catheter, and then a sheath. Like they're all loads better than another. They're like 10 times better. And so with the SMA, I don't care that you're going to reflux some contrast into the aorta, but I care about just pushing as much contrast as I can to overload the vascular territory. I want to see this bleed.
How are you getting the sheath in the SMA and how far?
Proximal. So I'll just put, I'll select it with a, Cobra, and then with the stiff glide or any, wire of your choice, I'll exchange the Cobra over that wire for a 6 French sheath. And then with the dilator, I'm not putting an 8 French sheath in the groin. I'm just going primary with that other 6 French and then hooking into there just so it's stable. And then I'll keep a wire in it, but I want to be proximal to the first branch, right? The middle colic. I want to pacify everything. I'll do my conventional run. I'm assuming, that's going to be negative. I just go into protocol. And my protocol now, I used to be pretty ginger, and if you look at the papers before, it'd be like a little bit here, a little bit there. I just give 10,000 units of heparin in the peripheral IV. If they're larger, I'll give 15. Yeah, I'll give 15,000. I give 10,000, give 15,000, right? Just
15 total or 10 and then 15?
No, 10 or 15 total, depending on how big the patient is.
Yeah.
And then at the same time, while they're prepping that and trying to give it to the patient, I'll give anywhere between, 200 to 500 mics of nitro. I honestly, I vary it up now. It's depending how fast I want this to go.
Yeah.
And so when I started, I would do 5,000 heparin IV and 200 mics of nitro. But literally, I've done this where I just do 10,000 and 500 mics of nitro. And I wait like a minute and then I'll do an angio. And frequently, I would say 10 to 15% of the time, that elicits the bleed.
Damn.
Like right there.
And are you doing are you doing just like one run of the whole SMA territory? Or are you doing like upper and then lower?
If your II is nice, right? I put the bed up, I put the II up. I'm trying to make the whole field of view because, I'm doing like
a long ass run.
Yeah, I'm doing 5 for 20.
Okay, you're doing it with the injector.
With the injector. So and something I like to do is I'll put 2 3-ways in tandem, and I'll put a flush line on the more end of it so that when I do my injections, I'm always flushing. That's a little bit more diagrammy that I could show, but I like 2 3-ways just so I have this like kind of a neuro setup, whatnot. So, but I'll do injector. I like having the injector, and again, I'm trying to flood the system, right? 5 for 20, 5 for 25, but we're doing a lot of runs, so you got to keep in mind the patient's renal function. If they're normal, I already plan I'm going to give like 350 cc's of contrast. It's just what it is.
Yeah, it is what it is because it doesn't hurt the kidneys anyway.
I know, especially if you're using Visipake or something, you're fine. But people can comment whatever they want after this episode. It's fine. But I think you can give it, if someone's renal function is poor, then it's something you have to think about, right? So then again, I do my run. I've become more impatient as I'm becoming older, right? So I used to wait 5 minutes, and then I would do my run, but I would wait about 2 minutes after the heparin, and I give the nitro intra-arterial, and I'm hoping to catch the whole, one view, but I'll try to get the most money shot I can, and I'll do my angio. And then if that's negative, I end up, TPA usually comes in these 2 milligram vials. So I'll either give, depending upon how I feel about the patient, I'll either give 6 milligrams or I'll give 10 slowly.
Okay.
I'm injecting, almost like maybe a milligram every 15, 20 seconds.
Are you diluting it at all?
Yeah. I mean, diluting it into I'll give a milligram per cc. So it says cc. Again, I just want it to kind of drip in there. But I'm not bolusing it, I'm letting it drip. I'm letting it take its time. And I'm giving takes me about 2 minutes to inject that syringe. And again, I have a flush line going. So it's kind of flushing and I'm letting things flush. I sit, I wait. I, at this time, already tell the nurse to start mixing the next 6 or 10 milligrams of TPA because it takes time. All of this takes time. And, it's hard to wait there for 6-7 minutes while they're mixing it, right? So I'm trying to not waste TPA, but at the same time, I'm not trying to waste time either, right? So at this point, while they're mixing, I'm waiting about 2-3 minutes, maybe 4, while I'm looking at my nurse's eyes, and people are starting to be like, whoa, what is this guy doing? Right? And then I'll do another run. Everything's connected. I have that sheath in the SMA, boom. And so I kind of repeat that. And now my max TPA I'll go to is 50 milligrams. Not that anything's ever happened at 50, but I feel like there's a limit you got to put somewhere.
That's a nice, good round number. So you're going somewhere between 6 and 10 at a time, and you're injecting it slowly and intermittently, after you give each dose, that's when you're doing your angio.
And then you see, again, you look closely. I like to have a second pair of eyes look at the angio, because you're going back and forth.
Totally.
And essentially, you'll do this like, oh, there's a little blush here. And again, it's just like, it's not like this big bleed that happens. It's just like little tiny blush. You're like, okay, there's the bleed, and then you go for it.
There's literally nothing worse than finishing a study, like a negative angio or something like that, and then you're at the workstation looking at it, and it's like, oh shit, there it is.
Yeah. Or what happened to me was I was doing a provocative and I missed it. And my buddy called me an hour later because he was looking at my study. He's like, did you see, what did you do about that bleed? And I was like, oh my God.
Exactly. I'll even sometimes like just step out of a case, take the gown off, sit down, and just start scrolling. Like it's like before we get out of
you should
there.
just sit and look, right? And it's where we miss things when we go fast. And again, you're looking at the same image over and over, and so your brain starts tuning peristalsis and gas out. But these bleeds are subtle, even though you're giving TPA. And so, I mean, literally that's my protocol, and I'll stop at 50. I mean, I'm not saying I've been positive in all my provocatives. I've been positive in the majority of them. My partner has made fun of me that I'm causing the bleed. I'm not, and so.
Well, what about the ones where you don't have any idea what side?
Yeah. So just before that, if I was thinking the other side, I would do IMA, but I'm not putting a sheath in the IMA. I'm putting a 5 French rim, SIM2, doing the same protocol, but it's way easier to overflow the IMA than the SMA, right? So same concept. 2 for 12 is usually my number that I'm pushing in there. A lot of times, especially in some of the smaller hospitals I was at, GI was not great, and literally they'd just be like, oh, this patient's bled before, we saw nothing, we're not going to scope this person anymore. It's just, it's fucking dumb, and it pissed me off so much, right? But then they come onto our plate, right? Patients like bleeding, and literally the GI just call IR, right? Negative CTA.
All the time.
So ticks on both sides of the colon, right? So I have no clue, right? And GI bleeding study negative, right? I'm like, okay, like I gotta cause this bleed to find it. This is the third admission. So I do bilateral groin, and same thing. I kind of, you could go single groin and you can alternate, right? But I'm trying to keep things easy. And like, why is bilateral groin scary? It's not, dude. You're closing both groins.
Dude, going back and forth sounds like the biggest pain in the ass. Like,
And then you can cause spasm. The last thing you want to do is spasm the IMA.
Spasm, and you're gonna miss you might miss the bleed.
Yeah. So you get your two catheters, but like, what's the big deal getting bilateral access? Like, it's just two accesses. Like, who cares, right? We do that in aortas and all this other stuff. Like, again, these are just what people have commented to me, thinking I'm like aggressive or are these myths. It's like, no, it's like, if you're doing a GI bleed, we're looking at both vessels. And so, you know, in this case, I would get my access, again, sheath in SMA, a reverse curve catheter in the IMA, and I would just alternate where I'm injecting the TPA. And I would do my run, and I go back and
you still
forth.
keep the limit of 50 combined between the two.
Yeah, sometimes I tell myself I have to stop there, but I've like wanted to do more.
Yeah. But that's when you're splitting, you're doing like 5 or 6 at a time instead of 10 at a time.
Yeah. I do like 5 at a time. Give it a chance. I have this theory, and the theory is not totally correct, but it's something where like the TPA is processed majority in your liver. So like the first pass is going through your gut and then getting through the portal system and getting processed, right? Or metabolized, I should say. And so the systemic effects of TPA are minimal. And so that's why I'm not worried about causing a head bleed or causing something. Now, the only thing that doesn't make sense in that theory, I believed in that theory for so long, but I had a couple of cases where I was focused on the IMA, probably because the GI told me it was coming from the IMA. And then I do and a step we didn't include is that if it's negative, then I make sure I check the celiac and the SMA, that I don't miss a bleed. And there has been times where in another vascular territory, there's the bleed. And who knows how long it's been going on.
Like,
yeah. I've already gave like 40 of TPA and IMA, and then I go to SMA and there's a bleed, you know, and I'm like, oh shit. And then I go for it. So there is some systemic effect, but I think it's very safe to do.
So you've identified the bleed. Like, what do you like to embolize with?
Making this embolize talk now.
I mean,
so
my favorite.
You know, I get selective. I like to get. I mean, it's almost like a challenge to myself. I want to get so selective that I'm in the bowel. Like I want my microcatheter to be in the bowel. Like then I know I'm like I did this right. So usually I'm using some sort of like tube French, like my True Select or something, and then I like liquid. You know, I haven't been on the lava train, but I like glue. But sometimes I'm so selective. I'm in this little vessel. I'm like, I'll just coil it, you know. And I like detachable coils. Northwestern was a big like, oh, only use that, so expensive. I like detachable coils.
Dude, I don't think I used a single detachable coil
in training.
In training, and it's exclusively what I use
exclusive.
Now.
I'm like, I don't want to use this Nestor tornado,
no way, man. Like
if you lose, like you just want to pack it nicely.
It is an increased cost with a very good reason. Like you do not want to fucking chase a coil that was,
you don't want it to it can look like it looks like an S. I'm like, no, I want it to look like a coil pack. Like we're IR, dude. We're not like a Joe Schmo embolizers, you know.
No, I'm with you. Look, if I can get really far out there, I'm going to coil, unless they're coagulopathic or something, and then it's glue for me. I do love glue.
I love glue too.
But I really like the combo of the True Select and the Embold in these tiny little branches.
I'm excited to try the Embold. I have it at my new hospital now. I was using Balt, which I thought was pretty good. Thought it took these turns and was very soft. But yeah, I mean, I'm a big liquid embolic guy, but I'd have to say for a GI bleed and you're selective, you're in that freaking 4th or 5th order, branch supplying that tick. You're literally at the bottom of the tick. Like, just put a coil and, it's pretty slick. So that's what I do. And that's my provocative angio.
I love it. I will try it. I'm going to try it. One of the myths that you busted for me is that I just assumed it was a huge pain in the ass. It doesn't sound that bad.
It's not. It's a couple of things, and these are some things where I learned the hard way, right? You want to say, okay, I want to get 50 milligrams of TPA, and then your nurse will be like they'll be like, what are you talking about? But you kind of tell them like, no, we're going to do it like this. Then they order it from the pharmacy, and the pharmacy gives you a bag of 50 milligrams of TPA, and you're like, holy shit, that thing costs like $20,000, right? So you really want to get the vials, and you want to not be wasting TPA. You don't want to give the nitro and heparin, and then you have this bag of 50 milligrams of TPA that you just 100%. Wasted. Okay. Yeah. So you kind of, and that kind of helps the nursing and the people in the room kind of think, okay, this guy's going in like little small bursts. It's okay. And at the end, when you know the number, you're like, okay, that's fine. So I think a pro tip is to use the vials, 2 milligram TPA vials, start making them or mixing them as you go, but, be one step ahead. Like when you're mixed one and you're giving one, tell them to start doing the next. Now we do these provocative angiogram protocols, and like the whole case takes an hour. Before it was like a 3-4 hour block, right?
Yeah. Wow.
And I don't call surgery. I don't tell them I'm doing this. I don't have like a backup surgical room. Now we established our program, right? We were fine. People knew we did this. If you're starting off, I'm also not trying to advocate for people to just be crazy. Like be smart. If you're going to start this at your hospital, make sure you make sure that anyone it tends to have eyes on your procedures, like you can justify yourself. There's data out there. Tell them what you're doing. It's safe. You do GA. You have your bases covered.
Yeah. I think GA is probably a huge step for that. Yeah.
It's huge because I'm telling you that breath hold is nice. And yeah, I mean, think about it. When's the last time you saw a bleed that you couldn't get to and embolize? Like, especially with liquids and stuff now.
Totally. You know where it is. Like, you're almost always going to be able to get there.
You're going to get it, right? So it's not going to be one where you cause this bleed and you're like, I can't stop it.
Right. Totally.
I'm sure there's stories out there and that's happened to someone and so it can happen. But I think, that shouldn't prevent you from doing this procedure that literally, out of all the patients we did, none re-bled, and now like when the paper that we had was like 44 patients. Now like we had done over 80, and none of those patients that were re-bleeders that we did this re-bled from the same site. We've had a couple bleed from a total different site, but it's a great procedure that's underutilized.
Yeah, absolutely.
And then the last thing you talked about, do you do it first? All right. So on your primary angio, there have been times now that I'm a little like I know where the bleed, say the CTA was positive and it's coming from the ileocolic branch and you do the angio and it's negative. What do you do, Mike?
Right.
Like what would you do right now? Like, it's negative angio?
Well, it depends on how good the CTA is. If the CTA is good, I'm going into the individual tiny little branch that they were bleeding from. I'm putting my microcatheter directly into that and I'm injecting. And there's a good chance it's going to be positive. And if I am like extraordinarily confident that is the right branch, I'll sometimes coil it.
You coil it. Yeah. Sometimes it's kind of hard, right? Like it's hard to directly correlate that branch to the, but sometimes
CTA.
You can. But like now you could just give 4 milligrams of TPA in the ileocolic branch and boom. Then, like it's a little talk about off label. It's just like we've done it. We've been safe and we've done it in a very careful setting. Non-GA, I wouldn't do it at like 2 a.m. GA bleed, but it's 10 a.m. The schedule is clear. Everyone's like nice and fresh. You talk to the patient before, you let them know you're doing something like this. I had the benefit, my patients were really like open to whatever, they trusted us and we would do things that would help them.
Plus a negative angio is just the dead worst.
It just sucks, It's just Friday, negative angio. You're scared you're going to get called in on Sunday for a rebleed.
Called in, plus it's like embolizing a lower GI bleed, so fun.
It is so much fun. I agree with you. That is like
a positive one. It's like, and then you find it in teeny little branch there. It's like, this is fancy. This is super fancy. This is, this is what I'm paid for.
I agree. And And it's so funny. We take it for so granted, right? Like, it's just like, oh, like you just, but like there's so much stuff and skill that we've learned to do it. And then it's such a remarkable result.
It is.
I think that's
like,
why it's so satisfying too.
Yeah,
right?
it's like
it's
because
microcatheter skills, it's diagnostic skills, it's decision-making skills, and it's all within like 20 minutes.
Yeah, I mean, these are teeny branches. I mean, this is, you would call this like a mega super duper selective embolization.
Yeah. Sometimes I'm like, I don't know what to dictate. Like, what branch is
what
this?
vessel?
Fourth order, like, I don't know.
The one that was
Vascular?
bleeding. Yeah, that's like
The
so
bleeding.
The nurse will ask you that, like when they're giving their report. It's like, which one did you embolize? The one that was bleeding. They get sick of that one. But
I know. I mean, yeah, I'm glad. I mean, yeah. I mean, what other kind of concerns do you have? Because I'm sure whatever concerns do you have is very similar to what the audience has for Provocative.
You answered them all. It's straightforward. It's more straightforward than I had anticipated.
Yeah. And again, I think the number is what people get really worried about. And even a lot of my partners that I was doing these cases and they would see me, when they would do it, they would be timid and they'd be like, no, we're not going to give more than 8. And I'm like, give more, it's okay, and I think if you can get over that, I think your positive success rate will be much more higher in these cases. And I think maybe one day there'll be more data. I mean, I think the data is so like sparse and random, there's just these, case series, etc. that, but the GI docs, they love it. Like they loved it.
I bet they do.
They would just be like, can you do provocative on this? Can you do, like, they're tired of seeing this patient come in again.
Totally.
And like, no one wants to do, we didn't have like the double balloon enteroscopy to look for like small bowel bleeds. Like just do this, but carefully. You got to be careful, right? But hopefully people don't hear this and think I'm just like a crazy.
No, I think you have a very reasonable strategy and rationale. Like what is the next step for these patients if you don't do this? You look at it that way. Like a lot of these people are going to get a major surgery.
True. And like, or they just like let them bleed and transfuse and then like go hospice. It's sad. One of the hospitals I went to, major hospitals in downtown LA, like they just would, the care was so weird. They'd just be like, okay, like just, they bleed, just put them on hospice. Fine, yeah, maybe the patient's 88 years old, but like they just have a GI bleed and you could stop it, right? So I hope, that this episode helps people as a reference. Again, that's the protocol. There's no set thing. You can adjust. You can go slower if you want and you're starting. You don't have to give 6. You can give 4. You can give 2. You can give 5,000 heparin, not 10,000. But again, if you want to increase your success rate, just give more until they bleed from somewhere else. I'll give you one story. So there was one. Okay, so there was a patient where we did an angio, was negative, and then he bled again that night. And so I had to do him the next day. And we prepped the groin and everything, right? And I put my ultrasound and I see a pseudoid from our access from the day before. Okay. So I look and like I'm all prepped, GA for this provocative. And I said, I'm gonna put my money where my mouth is, right? So I got access on the other groin and I do the provocative while keeping full eyes on the pseudoid and the groin. I give 30 milligrams of TPA in that case. Got the bleed, and then pseudoid was fine, never bled,
Yeah.
and I treated the pseudoid after that.
How'd you treat it?
Thrombin.
You just thrombin? Yeah.
Yeah. But I wanted to see how systemic it would be. And I was always looking at it. It's kind of an internal test, and I knew if it bled, I would control it right then and there. I had up and over access. I had everything I needed. But it just goes to show you how safe it is. You might have to cut that story out. Now I'm wondering if that should be public.
No, there's nothing wrong with that. That's
I know.
totally reasonable. It's a normal story.
I know. It's a normal story, right? But yeah, so yeah. I think it should be a good procedure for people to see.
I'm going to try it. I would expect you're going to get a lot of text or emails about this.
Yeah, man, people might be mad.
No. I think asking you how to do it.
I think so. And again, what I described here in this episode was nothing fancy. It's what we do for every GI bleed. The only things are sheath and the SMA. whether or not this is provocative, I highly recommend you guys do your SMA runs through a sheath. Your images are better, just through more crisp, you get better runs. And literally, those are the numbers I use and are comfortable with and have pretty good results.
Right on. Well, thanks for sharing it. I look forward to using it and looking forward to doing another one of these.
Yeah. Thanks, Mike. Appreciate it.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabeen Dhand,
And Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.